Good afternoon or good morning, depending on where in the country you live. Welcome. My name is Sabrina Corlette. I am a research professor and co-director of the Center on Health Insurance Reforms at Georgetown University's McCourt School of Public Policy. I will be your moderator today as we explore the kinds of approaches that state and federal policymakers can take to address the harms that stem from the corporate transformation of healthcare. Next slide, please. For those of you not familiar with our center, we are a team of experts who study how health insurance works and sometimes doesn't work for people. We publish real-world research and timely policy analysis to help state and federal policymakers find solutions that improve insurance so that everyone can get the coverage and care that they need at a price that they can afford. Next slide, please. Before we begin, I want to thank Arnold Ventures for sponsoring today's event and to also go over a few quick logistics. First, this webinar is being recorded. Everyone will receive an email early next week with a link to the recording. The recording will also be posted on our website. Second, we welcome you to use the chat to introduce yourselves, share reactions, and connect. And if you have any technical issues, drop those into the chat as well. And our producer, Nikita Binanula, will do her best to help you. Finally, this is a discussion, and while I will be asking our guests some questions of my own, we hope you will also submit questions for our speakers. You can drop your questions into the Q&A box at the bottom of your screen at any time during this webinar, and we will do our best to respond to as many questions as we can. This is the final webinar in a three-part series exploring the corporate transformation of healthcare. In our first webinar, we considered the impact of growing corporatization on patients and on physicians. In our second webinar, we dug into the incentives that are driving all of these mergers and acquisitions and other market activity in our healthcare system. And you can watch the recording for both of those webinars using a link in the chat. And we also have some accompanying publications, which we'll also drop into the chat. Our most recent publication focuses on the spectrum of policy actions and reforms that policymakers could pursue to protect consumers who are caught in the middle of all of this change. And that's what we're here to discuss today. I'm going to start with a quick overview of the kinds of policy options that could improve competition and increase affordability. This is not an all-inclusive list, but these are policies that have been adopted or pursued by different states. After that overview, I will introduce our panelists and ask them to share their honest reflections about how feasible these approaches are in today's current political climate and what their best advice is for their peers working in state houses across the country, as well as for federal policymakers who are, of course, also concerned about the growing costs in our healthcare system. So here we go. So I'm going to talk about a real continuum of policy options, and I'm borrowing heavily from a really helpful report that was published a year or so ago by the United States Congressional Budget Office. They outlined sort of three essential buckets of policies that can help improve affordability, enhance competition, and curtail excessive charges by large corporate healthcare systems. In one bucket, you have transparency of prices, ownership, and billing practices. In another bucket, you have promoting competition among providers and payers and others in the healthcare sectors. And in the third and final bucket, you have capping the level or growth rate of provider prices or regulating billing practices. And when the Congressional Budget Office looked at these sort of three major buckets, they estimated that transparency, while requiring relatively minimal government intervention, would also have pretty minimal impact on healthcare affordability. On the other hand, they project that greater antitrust enforcement, as well as caps or regulation of provider prices, would have a greater effect on affordability. So we'll move along this continuum, starting with transparency. And there are really a range of options for policymakers with respect to transparency. And they range from simply publishing reports, using state level agencies to publish analyses of local market conditions, cost drivers in the system, price outliers, and consumer pain points can really be important ways to educate the public and policymakers about systemic problems and help them target solutions. Of course, we also have seen a number of states try to build up the data that can support such reports by establishing all payer claims databases, or APCDs. In fact, more than 30 states have or are considering establishing an APCD. We've also seen states move along policies to require billing location transparency. And the reason this is important is that it would require off-campus outpatient offices to use a provider identifier when filing claims. This would reveal where patients are getting their care and help payers understand the total price for each episode of care. And this gives, of course, policymakers insight into payment rate variations and the potential impact of price regulation proposals. A number of states are also looking at ownership transparency, requiring entities to report before transactions about changes in ownership that can really help lift the veil on who's controlling the interests, who are the controlling interests behind hospitals, nursing homes, physician practices, and other providers. And then last but not least on this list, states play an important role enforcing and building on federal price transparency requirements. Folks might be aware that under federal rules, hospitals and payers are required to publicly post details of their charges and negotiated reimbursement rates. With improvements, they're far from perfect, but with improvements, these files could be really important sources of information about cost drivers and the market power of providers and payers. Next slide, please. So moving on in the continuum to antitrust oversight and enforcement, here again, a range of activities that states could pursue. First and foremost, just increasing antitrust enforcement to expand the range of reviewable transactions, require prior notice of those transactions, empower regulators to block transactions without a court order, and of course, just to increase resources for your antitrust agency. We've also seen a number of states move to prohibit what we call anti-competitive contracting. This is where large consolidated provider systems are requiring clauses in their contracts that limit competition and can increase costs. These include all or nothing, anti-steering, anti-tiering clauses, and most favored nation provisions. Prohibiting these terms can help bring costs down. And then we've also seen a number of states, and I think we'll hear from some of our state officials on this webinar today about this, moving to more actively oversee market transactions by requiring entities to report to an oversight body and empowering that body to review and estimate the anti-competitive effects of transactions, to approve them or approve them with conditions, or even disapprove those transactions. Next slide, please. The third bucket of activity relates to price and billing regulation. And again, here, there's a continuum of activity. A number of states have established a cost growth target or benchmark. These can be useful targets to help policymakers and the public understand reasonable rates of healthcare cost growth, enable states to collect data on their spending and identify the drivers of cost growth. We've also seen states move to ban facility fees or require site-neutral payment. This is where states are looking to require hospitals and outpatient providers to bill commercial insurance no more than a set multiple of the Medicare rate for certain services. A number of states have or are looking at enhancing health insurance rate review programs. This is where states are leveraging their insurance departments annual rate review process to help ensure that insurance companies are driving the best possible bargain with hospitals and other healthcare providers, and to actively constrain the growth of provider prices. Rhode Island's program is the longest standing of these and has resulted in significant consumer savings. A few states, and one of them is on this call, Washington, have established a public option health plan to help make premiums more affordable by adjusting or regulating provider prices. We have also seen a number of states in their state employee health plan implement reference pricing, where there's a cap or reference price for provider reimbursement in their plan. And then last but not least, and certainly one that does involve more engagement from the government, are states with all-payer rate setting or hospital global budgeting. Maryland is the only state that has an all-payer rate setting system, but Delaware has recently enacted price growth caps for hospital providers. And while this is, of course, requires greater government intervention, it also can have lead to some of the most significant impacts on healthcare affordability. Okay, that is my lightning round of a pretty wide range of policy options. So I'm now going to turn to our speakers today, and I'm so excited to introduce this panel because they're just fantastic. We really wanted to make sure that you would hear from people who have been grappling with these issues on the ground so you can get their firsthand real-world take. We have state officials and experts who span both coasts and the center of the country, because I think that's going to bring some real depth and texture to our conversation today. So here they are. We have two representatives tag teaming from Washington. We have Jane Beyer, a senior health policy advisor at the Washington State Office of the Insurance Commissioner. And she's joined by Evan Klein, who is the Special Assistant for Legislative and Policy Affairs at Washington State's Healthcare Authority. Next, we have Charles Miller, who is Director of Health and Economic Mobility Policy at the public policy think tank Texas 2036. And last but most definitely not least, we have Meg Garratt-Reed. She is Executive Director of the Office of Affordable Healthcare in the state of Maine. Welcome, all of you. We're going to make sure we have plenty of time for audience questions, but I'm going to kick things off with some questions of my own. I can't wait to hear from all of you, and I know our audience feels the same way. But speaking of our audience, I just want to remind people, if you have a question, you can submit it at any point in time in the Q&A box on the bottom of your screen. And we'll be watching that box as we go along and pulling those questions out so that we can ask our panel. All right, so folks, I just, in a very, very superficial way, walked us through several different actions and reforms that could be pursued either by state legislatures or through executive branch action. I would love to hear from each of you your opinions on some of these options, and specifically what has worked in your state and why. I think for this, I will start with you, Charles, if you're game. Would love to hear your reactions to this continuum of options, but also what's working in Texas right now.
Yeah, well, thanks for having me on. I work for a group called Texas 2036. We're a bipartisan think tank, for lack of a better term. And we really center ourselves not on ideology, one side or the other, but on the evidence and the data. I think you presented a great spectrum of options. And what's awesome about it is that some of those work great for a red state like ours, and some of them don't, but we can still make progress with the ones that do. Texas is very, very red, as you guys know, and love our free markets. And so when we look at something like price regulation, for the most part, that's not a starter for us. But there's a lot of stuff that we can do around transparency and increasingly in the antitrust option. So over the last couple of sessions, we've had a slew of bills around transparency. We established an all-payer claims database a couple of years ago, and I'm pretty confident we're going to get it funded this time around so we can actually start getting some useful reports out of that. There has been codification of those federal price transparency rules and even an expansion of that to other provider types. We've done some billing transparency so that you get an itemized bill before you're actually asked to pay items from your hospital. And then a couple items that are coming up this session that have a lot of momentum are a meaningful price estimate, so that it would be an estimate that you get within 24 hours. It's actually enforceable, as opposed to not having no protection there. And then the other two mentioned were billing location transparency. That's part of a omnibus facility fee effort that's been proposed. Seems to have a lot of interest there. And then ownership transparency. There was a bill that was filed about 4 days ago that modeled after National Academy of State Health Policy on ownership transparency. These have all been really, really helpful, not only in their own right, but as I talk with legislators in Texas, they are interested in how can we make the market work to drive this down. There is a fundamental belief in competitive marketplaces here, and we have addressed this by saying we need to make sure that our healthcare markets are healthy and operating functionally. And the 3 steps of a market that we always talk about are making sure that that market is informed. And so that's that transparency we talk about, making sure it's competitive, that people have choices so that they can do something with that information. And then the third one's a little more complex. We call it engagement. And it's making sure that the benefit plan designs that we have are incentivizing what we want to see happen. And whether that's incentivizing providers to provide the care, the high value care that we want, or incentivizing patients to seek out that high value care, structuring those plans in an intelligent way to align those incentives. And when we talk about all of that with this market focus and market mentality, and then look and see where the market isn't working, we can really work with those legislators to collaborate within this market-based ethos. And when we identified this and started talking to employers, this is where we were able to make progress on this next step. One of the options there was this banning certain anti-competitive contracting practices. If I had gone into the Texas legislature 5-10 years ago and suggested this, it would have been a complete non-starter. But last session, we got this passed. And we got it passed because we went in and we worked with legislators to say, okay, if we want to do something on this market level and we want to rely on our employers to negotiate these contracts, what are the barriers that they're having to do so, and brought them in to talk about the struggles that they were facing in this contracting practice, and the things that they were facing. And hearing from that enabled us to go address this in a targeted way. So we've had some success just really meeting legislatures where they are, and there is a bipartisan support for this. Most of the stuff that we're pushing has received widespread bipartisan support.
Wow, it's amazing to hear everything that's going on in Texas. You just ticked off a lot of policies, and we definitely want to dig in a little bit more. But I want to turn now to Meg with the same question I asked Charles, which is sort of your thoughts on sort of policies that can address affordability and a sort of corporatization of healthcare, and what's been working in Maine. What are you working on these days?
Yeah, thanks, Sabrina. And tough act to follow. That is a lot of action happening in Texas. Again, Meg Garratt-Reed, and I just wanted to briefly give a little bit of information on the Office of Affordable Healthcare. We're an independent executive agency in Maine state government. We are very small. There are 3 of us on the OAHC team right now, and we're also quite new. We've existed for just 2 years now. So I say that to give some context that my perspectives are sort of shared from a state that's relatively early, I think, on this journey, at least in sort of today's era. So it's been exciting. Our charge is very broad. We are tasked with analyzing healthcare spending and providing recommendations back to our legislature. And it's been great to be able to look holistically. I think until recently, lots of focus on insurance in our state and lots of regulation there, but we can sort of look beyond that and look to bigger factors in the health system. So with that being said, I think what I've seen work the best for us in early stages is really focusing on that transparency piece. And I know in Sabrina's presentation, there's a focus on the price or the affordability that's achieved by transparency alone, which may be limited. But I think as a foundation for future policy, it's really important as a first step. So we have been able to work with our APCD, Maine Health Data Organization. We're very fortunate. We have a very robust APCD here with a lot of experience. So we've collaborated with them on creating a set of hospital payment and utilization dashboards that we published back in the fall. Again, just to give legislators and others, I think, a little bit more of a look behind the curtain and beyond the high level view of healthcare spending in the state, to understand how particularly utilization and then payments per unit, a function of prices essentially, are driving that spending, so that we can understand and target solutions a little bit better. And I think that that's something really important in this space, because for those of us in health policy or health research, I think we sometimes jump to the conclusion that everyone has a sense of, for example, how medical trend drives premiums, but that's not always something that legislators themselves or members of the public are aware of. So I think we've seen that be really effective in just helping, again, to identify the problem, which is a step away from solutions, but an important first step. And I think in addition to that, we have been thinking about improving that transparency and building on it. So one thing we did just last session is there was a bill that passed on adding location identifiers to data. It's a tricky thing to do technically in some cases, but I think will be helpful to us in the granularity of that data and how we can use it. And then looking ahead, I can't quite say that this has worked in Maine so far, to be fair, but something that we are working with legislators and stakeholders on right now actually is a market oversight bill. So looking to be able to have a better view and a more comprehensive view into transactions happening here in the state, as well as a little bit more transparency of not just claims information about hospitals and health system, but also ownership information and information about their sort of organizational structure as well, that I think is helpful, particularly in terms of looking ahead at kind of corporatization. And just briefly, our state is one that has not seen a lot of kind of penetration of large national health systems. We do have a fairly consolidated hospital landscape, but it's mostly regional or even state-only local nonprofit. So we're kind of thinking from a protective perspective of how can we think about the way that the landscape of healthcare is shifting and take proactive steps to have a little bit more oversight and a little bit more involvement, which I think is appropriate given the consequences of some of these transactions for the people of our state and the constituents of legislators. So to be determined if that is successful this session, but I think it's been an issue that's been really resonant for people, and there's been a lot of interest in collaborating on that effort. So that's where things stand here in Maine as of right now.
That's so interesting, and I think always smart to try to be ahead of the trend and not have to be trying to apply solutions after the damage has been done. Jane and Evan, I would love to hear from you about policy options, either that I ticked off in my presentation, or maybe there are some other ones that you guys are pursuing in Washington. Would love to hear about what you think is feasible in your state.
Yeah, that's great. And I'm going to lead us off. I'll hand it to Jane, and she'll pass it back to talk a little bit about what we're working on this legislative session. So I'm Evan Klein. I'm with our state's healthcare authority here in Washington. I just want to start by reiterating a lot of what Meg noted, that this is a continuum of work for us, and something that we've been progressing over the past couple of years, even in a state like Washington that's been relatively progressive around affordability policy, transaction review, market oversight. We have had to build this work. And so it really started, I think, back in kind of 2014 in terms of recent work around development of our state's all-payer claims database. We have instituted some price transparency regulations for pharmaceuticals. We have a state public option that was implemented in 2019 for kind of a small subset of our individual market, and then have built on that with a cost transparency board, a prescription drug affordability board, and more recently starting to expand our thinking around reference pricing and some other market oversight strategies. But Jane, I think, is going to talk a little about some of the groundwork that her agency has laid for what we're working on this session.
Thanks, Evan, and Sabrina, thanks for the opportunity to share. So for those who are state policy people who are listening in, just sort of do a virtual, how many times in your legislature have you talked about policies that other states have adopted and had a legislator say back to you, yeah, but what would happen if we did it in Washington? And so the legislature, fortunately, a couple of years ago, directed our office to put together an affordability report. And we did two main things. We had a preliminary and a final report. And the two main things that we addressed in that report were, so what does the business of healthcare look like in Washington state? And of course, there we discovered, which probably a lot of you discovered, that we don't know as much as we need to know about the structure of both insurers and their holding companies and health systems. But the other thing that we did was we took 5 policy options and ran them through an actuarial analysis using our all-payer claims database to answer the question, what would happen if we did it in Washington state? And we think that that report has really been a great way to focus the discussion and to really be able to be more concrete about what we're doing. And when legislators saw the preliminary report and saw, well, we really don't know who owns what, that yielded a proposal this session to work on ownership registry. And again, like Charles, we were working from the NASHB model. So there's a bill that's still alive. And we are focused on transparency, not just on the healthcare provider side, but on the insurer and holding company side. And there is a lot of interest in Washington state around private equity ownership. We don't have as much PE penetration here as there is in Texas, for example, or in the Southeast. So again, I think there's interest by the legislature in staying ahead of what they're seeing. And I'm going to hand it back to Evan to talk about reference-based pricing.
Yeah, and I think the other thing that this report and some of the previous work we've done set us up for was to advance a proposal from our agency this session around reference pricing in our public and school employee benefits program. So we had some lessons that we were able to learn from our kind of sisters down in Oregon and kind of facilitated conversation with the data that was produced by our Office of the Insurance Commissioner in this report to come in and say, hey, there's some additional steps that we need to take to control prices, and our kind of next place to look is for our public servants in the state. And so we're looking to build on the policy that Oregon has in place around establishing a cap on hospital prices, but we're adding to that this theory that there's some redistribution of funding that's necessary in the delivery system, again, facilitated by the report that, in addition to some of the transaction pieces Jane highlighted, also emphasizes that we're underpaying for certain services, particularly mental health and substance use disorder services in commercial insurance. And so we have some behavioral health related payment floors, also primary care payment floors in our legislation. And I'm excited to note that this bill just moved out of our Senate Ways and Means Committee yesterday. So it's still advancing in the legislature this session, bringing some hopeful price relief to our state and school employees.
Well, thank you, Jane and Evan. I think first of all, it's wonderful to hear about the range of activity coming from 3 states, diverse geographically, politically, and everything else. But I think what you're doing is very hard. And so I commend you. But there are big headwinds. There are important, critical stakeholders who care a lot about these issues and want to engage on them that can sometimes make it difficult to get these bills over the finish line, get them implemented in a way that you want them implemented. So my last question to you, each of you, before we turn to the audience is, what advice do you have for your peers in other states who are thinking about these options? What should they be taking into consideration? How should they be making the case in terms of the impact that these range of reforms would have on their districts or communities? And maybe Charles, we'll just sort of do another round. I'll start with you.
I think the first piece of advice that I can give is when there are opponents to these pieces of legislation, listen to the arguments they make, because those are the arguments that your legislators are listening to. And what we found was a prevailing conventional wisdom in Texas that was kind of preventing things going forward was, one, that markets were working fine as is, and that two, the reason why prices were so high in the commercial sector was because of this concept of cost shifting, that our hospitals had to pay so much in charity care and uncompensated care, and the only place for that to be made up was on the commercial price size. So we heard that argument, and we went and looked at the data on this. And fortunately, there's this wonderful data tool, the Nashby Hospital Cost Tool, that we went and looked at, and they've analyzed this. And there's this wonderful number that breaks down precisely this question, and it's this commercial break-even number. And it looks at a particular hospital and says, taking into account all other sources of revenue and all other sources of expenses, what is the amount that commercial payers would need to pay as a percent of Medicare in order for that hospital to break even? And that amount is the amount of legitimate cost shift. And then we compare that amount to the amount that commercial payers are actually paying. And there's just a huge, huge delta. And it's not explained by any other factor other than market power and consolidation. And so we took this data and we put it into a tool and visualized this and broke it down by legislative districts. So each legislator had all of the hospitals in their district that they could then compare the story that they were getting from them with the data that these hospitals were reporting to the federal government. And this opened up all sorts of opportunities for us to go in and push reforms because we had data to support our side that wasn't matching up the story that they were hearing otherwise. So listen to the arguments that you hear against, and then go in and respond to them with data. It is really powerful.
All right, great tip. Meg, I'll go to you next.
Yeah, one thing I would say is thinking about a focus on how to make these issues salient for people. This is health economics, and I think it's really easy to get very theoretical and talk about kind of bending a curve over time. But one thing I think we've tried to do is really talk about what can the impact on people be. So thinking about private equity involvement in healthcare, think about a story like Steward Healthcare, where something has gone really terribly wrong in a way that's easy for people to understand and see the impact on themselves is one way. Or thinking about the impact of healthcare costs on premiums. I think because consumers are kind of removed from underlying prices because of the role that insurance plays in their perception of healthcare costs, there's always a lot of focus there, both by the public and I think legislators as well. So one thing we did was we were able to work with Wakely and Health Management Associates to do an analysis of rate filings in our market that actually quantified the impact of medical utilization and unit prices on the premiums that people are paying, which I think really helps to, again, just help people understand and make the connection to the way that they're experiencing the healthcare system. So I think doing that and also think about the economic impact as well. And again, being able to quantify or describe what it looks like when businesses are unable to hire more or increase wages because of the increases in premiums or overall health spending that they're experiencing. Just ways to really help people understand that this isn't just a theoretical policy debate, but something that has real consequences for our people and our states would be my piece of advice to try to overcome those headwinds.
Awesome. Thank you, Meg. And before I turn it to Jane and Evan, just a reminder, if you have questions, please put them in the Q&A box at the bottom of your screen. We will be turning to audience Q&A next. Jane and Evan, what advice would you provide?
So I think of a couple of things. When a hospital comes in and says, we're being underpaid, just to try to set the context and think about all of the entities that are out there, the employers who are trying to buy health insurance for their employees, the individuals who are purchasing coverage themselves. What kinds of changes, what kinds of not going out and making purchases, balancing between paying your healthcare bills and buying new sneakers for your kids, or for a small employer, what kind of balances around being able to pay your employees as much as you want to pay your employees. All of the people who are purchasing insurance are having to make really tough decisions in order to afford health insurance. So it's not just about whether a hospital is being paid enough to meet their costs as they define what their costs are. And then the only other thing that we've been thinking about is when an individual hospital comes in to make an argument, to think about the enterprise that the hospital is part of, which might be a multi-hospital system that owns physician practices and imaging centers and nursing homes and home health agencies, that it's not just a single hospital. I'll turn it over to Evan.
Yeah, thanks. So I kind of want to make 2 points. They're a little distinct, but I think they're both important. And the first is I want to emphasize like coalition building, right? A lot of this work struggles to, find success or grounding in a legislative environment when it's purely the data. I think we can drive initiatives so far when it comes to transparency, even market oversight. But when it comes to actual price related reforms, changes to the delivery system, I found that, health policy wonks or us and state agencies, we're not the best messengers. And it's really important to have those individuals who are most heavily impacted by those policies speaking on behalf of them. And we found a lot of success when we've had teachers and public servants, other public employees who are impacted by price reforms, consumer advocates, folks from industry and business come and talk about the need here. There's a broken market, and it's impacting them and it's impacting their lives, because really that's where all of this work initiates, right? It's grounded in the fact that people can't afford their healthcare, and that's where we need to kind of circle back with the conversation with our legislature. And then the other piece that I think we've found success with in Washington, and to be frank, I think is important, is it's not just hospitals, right? They're a major driver of the prices in the system, but there are a number of other issues with our delivery system when it comes to price and when it comes to regulation. And so I feel like Washington has found success in taking a yes and approach, acknowledging that there's going to be finger pointing about the problem isn't us. It's, it's pharmaceutical costs. It's, health carrier payment practices. It's, prior authorization. It's, market consolidation. And it's really hard to isolate one of those issues, take it on in a vacuum, and not have others, others in the industry kind of point back and say, well, there's other issues that we need to be dealing with. And when we're able to say, yeah, let's take those on too, because we recognize that inefficient prior authorization practices might be driving admin burden, or how we're paying, how our carriers are paying may not lead to timely claims payment and issues for our providers. And when we're able to do that, it softens the ground to say, and prices are still a problem, and we need to take on some regulatory intervention in that space as well.
Okay, this is great advice. So, thank you to our panel. We are starting to get some questions piling up in the Q&A box. So just a reminder, use the Q&A box to submit your questions, and we'll just start going through. So. Our first question comes in around private equity, and we did touch on this, but this person is asking, are any of your states doing anything to increase oversight of private equity firms in healthcare? Who wants to go first? Jane?
So we have a bill that is also about to clear a fiscal committee to put some structure around the corporate practice of medicine doctrine in Washington state. And the focus and goal of the bill is essentially keeping clinical decisions with clinicians. And I would say that's probably the most concrete thing I think that we're doing now. We have sort of a court-made corporate practice of medicine doctrine, but the goal here is to put more structure around it given the entry of private equity.
Great. Charles or Meg?
Yeah, I was going to say, we've got a bill that was filed. I mentioned that transparency of ownership bill that would show the extent to which private equity is in. I think we have a pretty good idea that private equity has made inroads. There have been, various sources of evidence indicating that, but having that actual required filings would give us concrete proof of where that is. And would allow us then to take kind of informed action in that regard. We have a corporate practice of medicine doctrine in Texas, but there are a number of loopholes and ways around that. And showing through that extent of ownership documentation might promote the opportunity for reform of that doctrine to be a little bit more meaningful.
Yeah, I was going to add concern about private equity was part of the prompt for the market oversight bill that we developed. We haven't taken a more targeted approach in part, I think, just because of the difficulties around actually isolating private equity and trying to address it kind of in a vacuum. I think oftentimes it's not actually the firm itself making an acquisition, for example. It might be a private equity backed health entity. So it was part of the inspiration, but we do have a slightly broader approach so that we can be more nuanced. I think to make a little pitch for the prior webinar in this series, there were some speakers who spoke about kind of a continuum of practices, I think, across the range of different types of entities. And, we don't want to close the door on private equity. There may be, or private equity firms, if there's investment in an organization that has a good track record. But likewise, maybe there's a for-profit that isn't actually private equity backed, but where we may have concerns about their approach or behavior. So I think we've tried to think a little bit more about the kind of outcomes and actions that we don't want to see and focus on that, as opposed to trying to make a clear distinction between kind of the structure or type of entity involved.
Great. So I love this next question. What could the academic research community do to support your work? Are there gaps that exist that could improve your groundwork?
I'm happy to jump in. I think there's an inevitable question about what should we be paying for healthcare services? We have a really good landscape view in our states, I think at least in Washington, of what we are paying today. And we recognize that what we are paying isn't translating to affordable access to services. And I think we would all sit here and suggest we don't want to press the balloon so hard that we completely destabilize the delivery system and no one can any longer access quality healthcare. But we also find it hard to subscribe to the premise that every dollar that we're spending on healthcare today is translating into either direct service delivery or is necessary. And I think this is a huge gap in our understanding, right? We have proxies that we can look to in other countries. We have examples of a facility here and there that's operating with a high volume of public payment, with a sufficient operating margin and relatively reasonable or low commercial insurance rates. But we can't even tell there, is that how much we need to be paying for these services? Is it how, there's a value proposition inherent in that discussion, but to the extent there's more research or analysis in that space, I know in Washington, I think that it would very much help our conversations.
I'd agree with that. I was going to say a very similar thing and maybe frame it just slightly differently as thinking about kind of opportunities and effectiveness of efficiency in hospitals or different healthcare settings. I think it comes into play in these conversations about acquisitions when sometimes there's a national firm that is saying they can somehow turn around a hospital and they're going to provide all the same services and the same staffing and just find ways to maximize revenue. And obviously we know some of the strategies employed there, but I think there's just interesting questions about why there is such variation in pricing across the country, even when controlling for other factors that I think would be really, really valuable in these conversations moving forward.
Can I use this to pitch my pet research project idea?
Yes.
It's a little nuanced here, but it is about the interplay of network adequacy, which is we all want to see network adequacy be justified on the basis of making sure that patients have access. But how does network adequacy interplay with the potential for market dominance? And when we talk about market dominance, generally we think, okay, well, do you have 30 or 40% market share? Does the existence of network adequacy requirements lower that threshold, or should it lower that threshold so that you need less of a market share when the predominant contractors and payers have to have more of that threshold of providers in their network to meet that? And how does that vary across states? Being able to have that and quantify how many effective monopolies there are in the healthcare space when they are required to be contracted with would be really helpful at having us look at the extent of the problem of market dominance, specifically with regard to healthcare. If anyone's interested in that, I'd love to talk with you more about how to partner on that.
All right. Charles
Yeah.
has put out the call.
Right. And I think Charles's point is especially well taken because we've had these discussions when we framed the issue for legislators. We've said this state has strong network adequacy standards. And if those network adequacy standards are giving more leverage to some of the larger systems that are operating in a critical rural county where a hospital has to be under contract, we're setting up we shouldn't be in a system where we have to sacrifice access to care in order to address price.
Okay. We have another question that crops up all the time, but I don't think we've gotten to it yet. So I'm going to ask, this questioner wants to know, can any of the panelists talk to how states have addressed the different needs of rural hospitals? And all of you have rural parts of your state. So different needs of rural hospitals when it comes to cost savings.
I'll jump in first and
Oh,
say
yeah.
that a frequent strategy we have is we treat them differently. When legislation is getting proposed that is trying to solve these market dynamics that really are impacting our major metro areas, frequently rurals get carved out. And that's not a perfect solution, but it is a expedient one that allows us to address this problem without unduly burdening some of our rural providers. But they are different and still working through how to get something better than that.
What I'd say in Maine is not all, but many of our rural hospitals are critical access hospitals. And in looking at financial and other data, we've actually seen that they generally are performing better financially. We, in our Medicaid program, they receive cost plus reimbursement as they do for Medicare. So, that may be one factor to include, but I think my answer then is less about how we treat them differently and maybe a little bit more of encouraging other states to really dig in and understand your own hospital landscape, because I think that's something that's different in Maine. Conventionally, the wisdom is sort of, oh, the rural hospitals are the ones that are struggling more. And we've tended to see more of kind of our mid-size in the middle hospitals being the ones that are a little bit more challenged because they don't necessarily have, maybe some of that preferential treatment or some of the other kind of advantages of critical access hospitals. So I totally agree with Charles. We do think differently about different categories of hospitals, but I also think that rural hospitals in one state can be very different from rural hospitals in another, and it's important to understand the status and the conditions that your own hospitals are operating under.
Yeah, and I'll just note, I think we've definitely struggled with this question a bit. We have some tools that are set up in the state. We have a distressed hospital grant program with funding available when hospitals are in, kind of reported financial need. We have certainly taken on kind of increased payments through our Medicaid program. We've largely carved out rural hospitals, as Charles pointed out, from price cap policies. We have a payment floor in our public option plan saying that the critical access and sole community hospitals need to be paid at least cost. We kind of started with that with our current reference pricing policy proposal for our public employees, and eventually it's moved to carving those facilities out, particularly the non-system critical access and rural hospitals. But I think there's still kind of an overarching question that, there's a need for some form of payment reform there. And sometimes it's not just, reimbursement for services, right? There's utilization challenges that make kind of encounter-based payments to those facilities really challenging for them to keep their lights on. We've worked on payment reform. We had a chart model kind of through the federal chart proposal, but really fell off when we got into negotiations and had conversations on the policy with hospitals because of some of the budget neutrality requirements. So I think there's more work to be done there, to be frank. but something we're keenly aware they're just unique challenges for those facilities.
Thank you. Another question about why are nonprofit hospital inpatient prices higher and growing faster? Has there been consideration of that? Is that anything you all can speak to?
I think there have been multiple sort of cost driver analyses that have been done in Washington State. Our Healthcare Cost Transparency Board probably has the most recent. My office, the Office of the Insurance Commissioner, did one a couple of years ago. And the cost drivers that we've tended to identify are it's prescription drugs, of course, as always, but rather than hospital inpatient, it has tended to be hospital outpatient, both from a price and a utilization perspective.
Any other thoughts on that one? I'll move on. We have a question. Many states are struggling with provider shortages, especially in primary care. Some corporate entities may seem to be attractive employment options for providers, but can create challenges for affordability and access to care for all residents. Have any of you thought about strategies for provider recruitment in light of the challenges posed by corporatization?
I think, first of all, we just have a supply issue nationwide. And we've been trying to address this in the short term, kind of in this zero-sum game of, okay, well, we're going to let, doctors who are licensed in other states come and work in our state. And that's great for us, but it doesn't help when, the state where the doctors are leaving from. Similarly, we do some things for international physicians. These are all short-term temporary solutions. We need to increase the workforce pipelines so that we can have a workforce that is responsive to our needs. And this is not even really necessarily unique to healthcare. This is overall, how are we aligning our education and training of our workforce programs to meet what our demonstrable needs are? I do think that in the longer term, we need to have a serious discussion exploring what level and types of care can be delivered in a different, maybe more efficient and perhaps automated environment to reduce the need for areas that have shortage of providers. And that's a tricky, difficult question about where to draw those lines. But if we aren't going to have providers available, how else can we deliver care?
And as Evan noted, when we did our research on reference-based pricing, if it were applied in the commercial market generally, we pointed out the disparities in payment between hospital services as percentage of Medicare and primary care and behavioral health services. And whenever we talk about the reference-based pricing proposal that's currently before the legislature, we always talk about it as an opportunity to rebalance spending.
Just reinforce that point. I think we think the same way that this conversation isn't always just about kind of constraining spending. It can also be thinking about a more rational system for how we are spending the money that we are to achieve the kind of outcomes that we want to see, which may be certain types of providers or more upstream care.
So I think this is going to need to be our last question, because our commitment in this webinar series is that we finish at 5 minutes before the hour so that people can move on to their next thing. So last question. I'm encouraged by Evan's reference to payment reform. Have other states seen success with payment reform models? I guess that's you and Charles and Meg. Have you guys seen success with payment reform models?
I don't think that there is a broad movement of payment reform in Texas. To the extent that there would be, it would be largely limited to the area where the government is a market actor. So maybe within our state employee benefit plans. That is large. It has about 1 million covered lives, but I think that's probably the extent to which we would see that.
I would say we have interest there, and I think there's been good progress in Maine, but a little bit stymied by silos, that there is a model for our Medicaid program and a Medicare model. And we've sometimes struggled, I think, to have the kind of cross-sector collaboration needed to try to figure out if we can align around some models. So that is one of the goals of our office actually as well, is to try to serve as a convener for more of that work. And very briefly, when we talked about rural hospitals, we talked a lot about exemptions, but I think there are things like Pennsylvania's global budget model that were really focused actually on creating more sustainability and predictability of budgets for rural hospitals. So challenging to design and implement for sure, but there is promise there, I think, that can be really responsive to local needs. So it's on the agenda too.
Excellent. Okay, so that's going to have to do it. I want to thank again Jane, Evan, Charles, and Meg. You guys were amazing. You really helped us bring some of these policy options to life, and you've given us a lot to chew on. I want to give thanks to everybody who joined us today throughout the series. We have really enjoyed these conversations, and we hope you have too. In fact, we hope you will tell us what you think. There will be a survey that will pop up on your screen once you leave the webinar. Please give us some feedback as we think about the next set of webinars, future topics. We'd love your input. Thank you again, and I hope to see you all again soon.